recording soon. We are recording. Yeah, we're in. Well, okay, right. Thank you for joining. We are today. We're going to record some questions from the audience regarding aspergillosis. This is a video sponsored by the Aspergillosis Trust, and we had a couple of frequently asked questions. Let's call it that way. And we thought we get the best people in the business to help us with these. Darius, you want to introduce yourselves?
Yeah, my name's Darius Armstrong James. I'm a professor of infectious diseases and medical mycology at Imperial College London, and with Anand, I run the fungal disease service at the Brompton.
Anand?
Hi, Bart. I'm a consultant respiratory physician at the Royal Brompton. Like Darius says, I run the fungal service with Darius, and also a clinical academic at Imperial College, with a focus on understanding and improving outcomes in fungal lung disease.
Perfect. Thank you so much. So the first question is from Mary Unsworth. As you know, a lot of us struggle with the journey to getting diagnosed. And if you would talk to a GP, what symptoms would you say, oh, you better have a look at aspergillosis here? What would you suggest they would think about? Darius, would you try to?
Yeah, so I mean, this is an incredibly important issue. Because we all know that people are being missed, not picked up late with aspergillosis. And I think many of your patients say that to us. We also know that from what we see and how long it takes patients to arrive in our clinic. And actually, part of the reason for that is because this is what we call an insidious disease, which means that, you know, it's not immediately obvious that you would have it. The symptoms that you would have might be very similar to others. In that, you know, you might have cough, breathlessness, perhaps some, you know, chest pain when you breathe in. Obviously, it depends whether or not you've got an infection or an allergy. You might get wheeze more, and we should always think about sinusitis as well, and sinus pain or discharge. I guess, you know, if we think about things that might give you a clue, I think either something like coughing up blood, that can be something that can be a little bit specific to Aspergillus. So that's perhaps suggesting that ought to be investigated. And apart from that, I guess that the other really important factor to appreciate is that we know that Aspergillus is affecting very specific types of individuals. So for instance, if you have a background of asthma or something like previous TB, sarcoidosis, COPD, these kind of individuals, or perhaps those with immunodeficiencies, are at increased risk of Aspergillus, and so there needs to be an increased awareness in that setting. And I think from a purely infection perspective, or actually from a chronic respiratory disease perspective, in particular, we're interested in people who are not responding to conventional antibiotics or steroid type therapies. So in that setting, if somehow the treatments aren't working and it's all a bit of a mystery, then think about Aspergillus.
Perfect. Jacqueline was asking, is there like a easy test for aspergillosis? Like, you know, we've all had the easy test for COVID, right? That kind of works. Does something like that exist for aspergillus, or are we building something like that? Anand?
Yeah, so there are a number of different tests that are available. I mean, the issue is that I think often they're not available until sort of secondary or tertiary care. So GPs don't often do those tests. And I think that's partly one of the problems. I mean, building on what Darius said, I think there are certain conditions which predispose to the disease. So I think when you have an underlying diagnosis of asthma, or particularly post other conditions like sarcoidosis or tuberculosis, or even chronic obstructive airways disease, I think the level of suspicion should be higher, and it should probably perhaps prompt a referral at an earlier stage where those tests are a little bit more available, because it's a balance between overusing tests, you know, in an area where perhaps there's not the expertise to understand when best to use them. So I think it's just having that referral stream and the suspicion, you know, when there's an underlying disease, which is often the case. But there's certainly more that can be done from a diagnostic perspective. You know, the tests that we have available at the moment are limited to certain types of molds. They're not necessarily routinely available to a wider range, and there's still a lot more that can be done from a diagnostic perspective, both microbiological and serological as well.
Thank you. Valentino's asking that if
Bart, can I just interrupt for a sec?
Please, yes.
I might just move to a separate office because I think we've got a bit of a.
I'll talk to your colleague while you do that. If
Yeah,
you could
okay.
mute, yeah. Okay, thank you.
Yeah,
So-
and whilst Anand's moving, Bart, I might just sort of do a bit more from the diagnostic side. So we both broadly from diagnosis of Aspergillus, we have criteria that we use, and those are basically either what we call serological tests, which are in blood, and those can either be to detect proteins from the fungus or antigens or antibodies, basically. So those are the serological tests we have. In addition, we look at whether or not we can detect it in the airway using sputum or bronchoalveolar lavage. And for that, there's traditional culture, but there's also PCR as well as a antigen assay. In fact, a lateral flow assay, which is similar to the lateral flows that people do for COVID. It's not been validated on sputum samples or any kind of nasal swabs or anything like that. So unfortunately, it does require bronchoalveolar lavage. And in addition, in fungal disease more broadly, radiology, so X-rays, CT scans, MRIs are really, really important because fungi will often give very specific features, basically. But of course, a lot of this is complex and tertiary sort of level, as Anand says. So getting any of those tests in a GP practice is quite tricky. And I think as a community, we do need to think about whether or not there is some primary care way that we can basically try to pick up people with Aspergillus at an early stage. That's an unsolved issue at the moment.
So, and that actually brings me immediately to Valentina Rao's question. For many of us, it takes years before we get diagnosed. If we would do this earlier, if you would really find a way of doing early diagnosis, would that give people the view to remission or to cure, or is that not realistic?
I think certainly for invasive Aspergillus, we know that the earlier you treat someone, the better the outcome. And we also know that once you have cavities, it's more difficult to clear. So I think there's some sort of indirect evidence that, we do need to be treating people earlier. In addition, we know that people who've got undiagnosed Aspergillus in the context of asthma may develop bronchiectasis, which, if we had treated them earlier, probably would not occur. So I think there is sort of direct and indirect evidence that, we do need to pick up people as early as we can with Aspergillosis. That's a really, really important thing.
I'd sort of concur with that. I think it's really imperative. So, a lot of the focus at the moment is picking up disease at an early stage. So if you separate them out, because obviously there's quite a big spectrum with Aspergillus, but from a chronic lung disease perspective, we know that bronchiectasis, once it's developed, is structurally irreversible, and it can lead to colonization and ongoing problems. Within the context of allergic bronchopulmonary aspergillosis, that's usually a reflection of when you have obstruction of the airways with eosinophils and fungus, which then leads to structural damage. Now, if you can detect that at an early stage, and we see this quite commonly, and get good control, then you don't develop that. You actually limit the structural disease, which is really what you're trying to achieve. And likewise, from a chronic cavitatory aspergillosis perspective, it's really important because, if there's an isolated issue in a particular segment of a lung without extensive structural damage around it, then it's potentially surgically resectable. And I think we often, unfortunately, diagnose people quite late on in the disease where, there's usually bilateral disease at both sides, and it becomes very difficult to consider that as an option. So again, from that perspective, it is something that's quite important to pick it up.
And actually, in that context, that's my question. Do we have any indication if this is hereditary, or we don't know anything about that?
I mean, the honest truth is that we don't know enough. Almost certainly there's a genetic element specifically for allergic bronchopulmonary aspergillosis. I think there's definitely a genetic element, but it's, and we know that because cystic fibrosis, for example, is a known genetic risk factor for for ABPA. But there are other genes that have been identified as well that are potentially important. But the large scale studies that are really required to define that in more detail haven't been done, because I think when you're looking at genetic wide association studies, you need thousands and thousands of patients to achieve power to be able to make those make that association. From a cavitatory point of view, there's usually an underlying risk factor with regards to the structural lung itself, but I think then it's a multiple hit issue. So I think there's equally then, when you look at it, perhaps a second genetic risk factor on the back of a structural lung problem which underlies it. So it's probably not quite so straightforward. It's a multiple hit issue. Although there are certain conditions, again, which are characteristically at risk. So hyper-IgE syndrome, again, they're much rarer conditions, but they're specific issues with fungal lung disease. But the honest truth is we don't know enough, and we need to develop the cohorts with large scales of numbers, probably globally, to really get the resolution that we need to work that out.
Okay,
yeah,
perfect.
I mean,
Yep.
there are, sorry, and just to add, there are some primary immune deficiencies, basically like chronic granulomatous disease, which presents in childhood with aspergillosis. And in addition, there have been mutations in the genes Dectin-1 and CARD9 that can also predispose. And I think one thing that Anand's been quite interested in is that in ABPA, there's quite a lot of patients who are carriers for cystic fibrosis. And it's worth screening for that if there's no good explanation as to why they're developing ABPA with bronchiectasis. Yeah. And obviously important to know if you're a carrier of cystic fibrosis.
So if I translate that in non-scientific language, it's like, as a patient, we're not entirely sure if your kids are more likely, but keep an eye open. And if you see the problems that are associated with aspergillosis, please have it checked out sooner rather than later. I think that's because we don't have the data at this point. Okay. Now, the next group of questions is around medication. Jacqueline Carter is asking, we had a talk a while ago about antifungal resistance. Are you aware of any new antifungal drugs that are going to help us when the current generation is no longer active?
Is it my turn now? I can't remember.
Yeah, please.
I think I'm the next one. So yeah, there are a number of drugs in development that are now in phase 2, phase 3 studies that are quite exciting. And I think if those can get through phase 3, which is traditionally, the hardest phase to get through, which is when they do the multinational studies, then we will be in a much stronger position. And those drugs, I mean, just broadly speaking, there's resofungin, which is basically a long-acting type of caspofungin, an echinocandin type drug, or micafungin that people have managed to take. So that's given once weekly, so obviously much better than giving it once daily. There's a brexafunga, which is actually an oral echinocandin-like drug, but it has much better penetration in the lung than the echinocandins. So it might actually be as good as the triazoles for Aspergillus. And then there's another drug called fosmanogepix, which is broken down to manogepix, which is basically a sort of pan-fungal agent, which is also looks very good. And finally, there is alorifim, which is the drug that's being developed by the Manchester group F2G, which is looking like it might be very useful for Aspergillus. I should also mention that we've done some spin-out work with a company called Palmicide at Imperial, and there's now a drug called opalconazole, which we've used in a number of patients at the Brompton, that appears to be good and is an inhaled treatment. So we've used that in a number of patients with different forms of airway aspergillosis, and those publications, we published most of them so far. So we've had good results with that, and that's an inhaled one.
Perfect. So there is a pipeline, and hopefully,
yeah,
excellent.
Yeah,
okay.
There is, and it's going to make it's hopefully going to help, but also will make, as clinicians, our lives much more interesting, complicated.
Yes, that's what we want. Now, actually, and then Leslie Alexander had a question, and perhaps Anand, you could help there. how do we decide what azole to put a patient on? Like, I think by default we get this one, itraconazole. Is that because it's the cheapest, or what's the thinking there?
So again, this probably highlights the lack of rigorous randomized control trials that are currently in this kind of sphere of chronic Aspergillus, because I think what you're referring to, I think, is really chronic Aspergillus disease there. Because obviously, from an invasive point of view, I think first line medications wouldn't be itraconazole; it would be usually voriconazole or some of the other newer azole therapies. In the context of chronic lung disease, so that's either allergic bronchopulmonary aspergillosis, the only drug that's actually entered randomized controlled trial really is itraconazole. So the evidence base is purely on itraconazole. In chronic pulmonary aspergillosis, there's a little bit of work using, well, I wouldn't say necessarily randomized controlled trials of any large degree, but there's some studies examining voriconazole and echinocandin based medication. But again, the largest experience is with itraconazole. So I think it's a combination of, that's where the evidence lies at the moment. It's probably the best tolerated out of the medications, and we know that tolerance is a really key factor in terms of the ability of people to stay on these medications for what's often a longer period of time. There is, however, a big unknown as to what the best first treatment should be in these conditions, and I think that's work that needs to be done in terms of trying to better understand that, in terms of, are we shooting ourselves in the foot by using the wrong medication first, developing resistance, and then when you come to require some of the newer azoles, they're not particularly effective. And certainly some of the newer drugs do have better bioavailability and pharmacokinetics in terms of how they're absorbed, and that maybe is important, but that evidence in the research has just not been done.
Okay, and so thank you very much. And that brings me immediately to the next question by Jacqueline Putney. Sorry, is it a given that if you take itraconazole for a long time, you will become resistant to it, or is that not a given?
I don't think it's a given, but there are some important provisos to that. So most of the resistance that we pick up in patients with chronic pulmonary aspergillosis, and it's been shown that resistance is particularly likely in people who've got lots of cavities. So that is, I think, the first point. In ABPA, we're not seeing much resistance, actually, and I think these are quite different conditions. So it's more the CPA where we see the issue. In addition, obviously, the amount of time that you're receiving the drug is really, really important. And I know that Anand might want to comment, because he also did some work to look at whether or not the level of itraconazole also predicts whether or not you're going to get resistance. I also think that underlying this, there's a really important point which needs to be made, which is that we know that there are resistance sort of strains of Aspergillus in the environment, and we're probably all inhaling those all the time, but they exist at a very low level, so probably less than sort of 0.1% in the air of what we breathe in is resistant Aspergillus. But of course, that means that if you purely ask me, am I going to develop resistance? It might not be that you develop it. It might be that you're just inhaling it all the time anyway. Okay. And it's actually what I would call a bit of a numbers game, but it's around, and being exposed to itraconazole is going to increase the likelihood that you develop something that's based on a resistant strain.
Anand, you want to comment?
Yeah, I mean, broadly, I'd agree with Darius. I think chronic cavitatory CPA, the likelihood of developing resistance is very, very high, unfortunately, when you're on long-term azole therapy. I think a really big question that in the field that needs to be answered, particularly when we're dealing with some of the newer drugs that are coming into the market, I think there's a feeling that I think if you use any drug in isolation for a length of time in chronic cavitatory disease, the resistance is inevitable to a degree. So there is a question, particularly in that context, whether combination therapy is going to be superior to monotherapy.
Okay.
And it's something that, again, is a really, really important question that we need to try and answer moving forward.
And actually, the next question from Lorraine Neville is in that direction as well. What's the the scientific literature on stop restart antifungal therapy?
So, I mean, the current evidence would suggest that. I mean, I think I'm presuming she's referring to, again, sort of chronic pulmonary aspergillosis primarily.
Yeah.
If I take kind of the chronic forms of Aspergillus, because that's really where you're looking at long-term therapy, ABPA. If I take that first, because I think that's perhaps a slightly easier one to pick apart. I think there it's slightly easier because obviously you can track the allergy over time, and then certainly in my experience, if you're starting treatment on the back of a really significant flare, I would tend to use 6 months or sometimes a year's worth of therapy. If things are very well controlled, then you can consider a break. But it does need very careful monitoring, because often what you'll find is that things will flare up again 4 to 6 months perhaps after you stop treatment. And it is a case of stopping and reassessing, and you can get some idea of that level of risk based on the serology in terms of how that looks now. Or equally, you can consider alternative-based therapies, and we haven't really talked about them, but there's a lot of excitement in the severe asthma field in terms of some of the biologic therapies that are available, where unfortunately ABPA hasn't really been included in the licensing. And I think, again, that's a really important topic for further research from a commercial industry perspective, to really see whether we can use these medications in ABPA, which then means we're not reliant on long-term, potentially toxic azole medications. From a chronic cavitatory point of view, the evidence base at the moment would suggest that 12 months of treatment is superior to a shorter duration at the initiation. What you do at that point is really a bit of an unknown, and often in certain cases, the progression is so severe that you stay on long-term therapy. The reason to stop is twofold, really. So one is the toxicity of the medication. The second one is obviously this idea that if you're having a break off therapy, does it reduce the risk of resistance development over time? All of those, though, is guesswork. We don't really have any good evidence to know whether, this sort of break and cycle approach is better than staying on the single drug. There's obviously the risk when you come off things relapsing and progressing. So I think it is very much an individualized decision with the patient, with their clinician, taking into account all of those factors and making a bespoke decision for that individual, because I don't think there's a single rule that meets all.
Perfect. Thank you very much. There's a question from Fran Pearson. There's actually, it is twofold. As you know, there's a big problem with azoles used in horticulture industry. And so the first question Fran has is, are you aware of any public policy being done there to alert the bulb industry that they are causing a big problem? And the second question is, as a patient, should we stop going out in certain circumstances, or should we just is it always better to go and go for a walk? So perhaps the first one, do you know anything about policy being done there?
So I mean, there have been some European reports on this essentially, and there are conversations that are occurring. I think Anand and I aren't involved with them because they're more around sort of environmental and ecology aspects. So I think Matt Fisher at Imperial has been involved a bit with that, and Paul Verwey in the Netherlands as well. I think he led some of the work that was done at a European level, and there was a document, I forget it, but we can try to dig that out and circulate it if it's of interest, Bart. So
I'll look it up. Don't worry.
There has been some work on that, and in addition, we've got funding from the Wellcome Trust at the moment that's led actually by Matt Fisher, but involves Mike Bromley at Manchester as well, where we are actually looking also at some of these novel antifungals that we're talking about, and whether or not there are equivalent drugs that are being used in agriculture. So this is also a forward-thinking issue, because it's going to continue with the newer drugs that we're seeing as well. So I think, it's a really, really important aspect, basically.
And in terms of friends asking also, should we, in some circumstances, decide to avoid some parts? Say where there are bulb agriculture.
I mean, that is a question that we know that there are hotspots. You're right, but we haven't proven that there are risks for patients. So it's quite hard for me to say to patients, don't do this and don't do that. But we do know, like it's been extensively published. So, for instance, plant bulbs, for tulips and things are, they're coated in azoles, and they're highly likely to harbour highly resistant Aspergillus. So I can't give you a medical recommendation, but I think I can give you some kind of practical common sense advice, basically, if you like, that obviously for certain individuals who are at risk of fungal disease, as we've discussed, don't go out and do composting. Definitely involve composting involving large amounts of tulip bulbs. And just try to limit exposure to mouldy environments, I guess, is for anyone with chronic respiratory disease or an immune problem. I think for the general public, it's not an issue.
Okay, perfect. There's a question from Dale Bush, which is might be a little bit specific, but we'll see. So they're asking, they're being treated with Cresemba isavuconazole, but they can't treat NTM at the same time. Do you have any understanding of that?
Yeah, so I mean, it's a common problem. So, particularly for patients with fungal disease, often there's a coexistent mycobacterial, non-tuberculous mycobacterial infection as well. And it's, if you look at the literature, probably about 30-40% of individuals with chronic pulmonary aspergillosis, it's a coexistent infection, and sometimes you get one preceding the other. So once you develop chronic cavitatory disease due to mycobacterial infection, be it TB or non-tuberculous mycobacterial infection, it's a good site for Aspergillus, and almost certainly they occupy the same environmental niche. So if you treat one, the other one flares up, which we see not uncommonly. The issue with treating both together is to do with the drug-drug interactions with the drugs that you would use, which makes it more complicated. I wouldn't say that you can't treat both at the same time, and we certainly have done, but it's more complicated, and I think you have to be very careful about which one you think is causing the problem, and which one you therefore think you want to treat. Sometimes you're in a situation where if you're trying to treat both, you're not perhaps on as optimal therapy as you would like, which I think then has its own implications. So certainly we have treated both if we feel that it's necessary, and I don't think being on an azole makes it impossible, but you do have to adjust the mycobacterial therapy on occasion. You have to adjust the antifungal therapy on occasion, and then monitor very, very carefully. So it's something that I would probably talk to. It requires very specialist input. So you really at that point should be under a tertiary level specialist looking after fungal disease on a regular basis.
Thank you. There's a question so we're now looking the final set of questions on the what's complications, what's outlook, and Jill Fairweather, that you all know, has observed that many patients with aspergillosis also develop bronchiectasis. And the question she has is that, is this like a natural progression, or can this be avoided, or is it just like we're being unlucky?
So it's an important observation, and it's quite interesting, because if I take the example of ABPA, allergic bronchopulmonary aspergillosis, we have some patients who do develop bronchiectasis and some who don't, and we don't understand why that is, but it seems that we should probably look at two things, which are basically coexisting infections, and also whether that individual has some kind of genetic differences, but we don't have the information yet. We are looking at that actively in our cohort of the Brompton, so it's something of great interest because it's important in terms of patients' outcomes. So yes, I mean, bronchiectasis does occur in some patients. It's probably in the most severe patients. We don't understand fully why that might be. I think it's also worth noting that some patients who have bronchiectasis for other reasons go on to develop aspergillosis. Probably the best example of that, or the best two examples of that, are cystic fibrosis, where they get secondary aspergillus infections, and also tuberculosis, which commonly does cause bronchiectatic disease, and then that leads to secondary aspergillus. So there's quite a complex interplay between the two. And I think within that, one of the big questions is whether or not the infection with Aspergillus itself and all of the nasty enzymes and things that it releases is contributing directly to the bronchiectasis, or whether or not it's just the way that the immune system is responding that's causing it.
Perfect. Go
Yeah,
ahead,
I agree.
Anand. Yeah.
I think just to add, I think from a very practical perspective, it's very common, and I think it's just really important to make sure that the focus isn't purely on targeting the fungus, because the bronchiectasis management is absolutely critical to make sure that you stay well. So that's real basic things like airway clearance, physiotherapy, treating any coexistent bacterial infections, and making sure there's no underlying etiological cause for the bronchiectasis outside of the fungus, like Darius is saying as well. I think what's very encouraging is there's a lot more interest, recently in terms of reinvigorating research within the general bronchiectasis group of patients, and I think there's a lot of interest in terms of novel therapies in that field as well, and it's just really important to make sure that individuals with ABPA are included in that as well, which historically perhaps has been an exclusion criteria for some of the studies. So it's really important that they're not again left out of any novel therapies or research coming through.
So as an aside, my understanding is that bronchiectasis is closely related to cystic fibrosis. It's like in my late term, it's like a milder form.
No, I mean, I think what I would say is that cystic fibrosis is one genetic cause of bronchiectasis. So bronchiectasis is it's a heterogeneous term. So what I mean by that is actually what bronchiectasis really means is it's a radiological description. So all it really means is it's based on the description of your CT findings, where you effectively have airways that are structurally abnormal and dilated as opposed to the corresponding blood vessel. Now, there's multiple causes of bronchiectasis. Some of those are genetic, cystic fibrosis being one example, but there are other genetic causes as well. There are also post-infective causes, which are globally probably the most common. So that's with tuberculosis, really. But equally, then there are other inflammatory causes as well, or immunodeficiency causes. So really, bronchiectasis is a bucket. That's just a description for multiple causes, CF being one of them.
Thank you. I love talking to scientists. Ross Sunley is asking, what's the relation between aspergillosis and colonized Pseudomonas?
I think that was yours, Anand.
Was it? Okay, sorry. I thought I was having a breather.
No.
So it's very similar to what I was just talking about. So it's a little bit like we're understanding more and more about the interaction between different pathogens within the lung. So obviously we all have a microbiome, which is all the bacteria that are within the body and within the lung specifically. But when you have diseased lung, you often pick up certain bugs, Pseudomonas being one of them that tends to affect chronic lung patients. And Aspergillus is unfortunately also an issue. But again, I think they occupy the same ecological niche, so the environmental niche, and almost certainly there's an interplay between the bacteria and the fungus, which we are only really just beginning to understand. So what you'll find is that, and there's been some good work within the cystic fibrosis literature and equally outside, is often when you find one, you find the other. So when you find a Pseudomonas, you find an Aspergillus and vice versa. And often when you, unfortunately for us, I think when you target one particular pathogen, it probably creates a very nice niche for another pathogen to come in, because they're all competing for the same micronutrients in the lung. And so we're really only just understanding that interaction between the different fungi and bacteria. And with some of the newer sequencing technologies, these are molecular diagnostics where we can look at the whole kingdoms of bacteria and fungi. We can start to get a much better idea of, if you, for example, target Aspergillus, okay, you're targeting the Aspergillus, but what is the implication on the rest of the whole bacteria fungal kingdom, and what are the secondary effects, which we're really only at the beginning of understanding. Going back to what I was saying before about that, just making sure that bronchiectasis is well managed. Again, if you have coexistent pseudomonal infection, really important not to ignore that and treat it if it's causing problems as well. Perfect.
Paula Taylor is asking if ABPA can cause chest pain and palpitations. Is that is there literature on that, or is that just like?
So I think certainly in terms of chest pain, in the patients that I look after, a lot of those patients will experience chest pain, which is what we call pleuritic pain. So that's basically when you breathe in or breathe out, or in certain positions. So yes, I think it can do, and I think it's particularly prominent where that bronchiectasis is near to the side of the chest, where the chest, where the lungs basically interact with the rib cage, which is called the pleural area. In addition, a subset of our patients do get what we call pleuroparenchymal fibroelastosis. It's not so common in ABPA, but certainly can occur, and that's where you've got scarring of the lining of the lung caused by inflammation. And so that's another potential area where you could get chest pain associated specifically with ABPA. The other sort of reason that we might see it is where there's a superadded infection or a flare, and you're getting lots of mucus plugging or a bacterial infection in the lung, and again that can cause pleuritic type chest pain. With regard to the other part of the question, sorry, I've forgotten what the other part was.
It's palpitations.
Yes.
Yeah. So palpitations, I don't think that ABPA would directly cause palpitations, but we do know that, for instance, if you're inhaling lots of salbutamol, that could cause palpitations. And in addition, some of the medications, so for instance, triazoles, can cause palpitations, although more commonly they cause weakness in the heart pumping, which can lead to fluid buildup. And so I think if you are having palpitations with ABPA, the first thing I would be doing is looking at your medication list very closely, and making sure there's nothing there that could be causing it.
Perfect.
Just to add, Bart, I mean, the
please.
one thing I was just going to say is that obviously, we're very focused on the fungal component of these conditions, but there is an increasing literature that, when you have bronchiectasis or when you have chronic inflammatory disease, you have a generalized increased inflammation, and there's a bit of evidence to suggest now that there may have implications in terms of cardiovascular disease as well. So that's been seen in, other corresponding conditions, and it's just really important not to ignore chest pain and palpitations, and make sure you do get it checked out to make sure there's not a coexistent, cardiovascular problem. So, making sure that's not a symptom of angina or, heart disease. So don't ignore those types of symptoms. Get it fully checked out.
Perfect. And I have one final question by Artie Crafty, and it's kind of by myself as well. Is looking forward. There is a lot of very fundamental research happening in many areas. Like we saw what happened with COVID and mRNA. All of a sudden, we realized actually we can build these medications very quickly. We have people looking at protein structures, protein folding. Is any of this likely or possible to have a game-changing impact in the next couple of years, or is it just a pipe dream? Is any fundamental research possible or likely to lead to dramatic changes in treatment, or is there no evidence of that at this point? Do we know anything about that?
I think when you're talking about the mRNA, if you're talking about from a vaccine perspective, I think that that there's been a long history of vaccine development for fungi, which has been littered with complication and a lot of difficulty, but that is actually being picked up again. There's some colleagues academically that are picking up that research, and I think there's perhaps some hope, but it is extremely complicated because fungi have evolved. They're eukaryotes like humans. They've evolved with us for millions of years, so they're much more complicated to develop vaccines against. But I think with some of the newer technologies, I think there's a bit more hope in that perspective. I think there's it's still quite a long way. It's in the very, very early preclinical phase of treatments. I think in terms of where the more perhaps immediate hopes are, I think from an ABPA perspective, there's a huge pipeline of anti-allergy type monoclonal antibody medications, which I think really could be game changing in terms of the ABPA field, in terms of achieving remission if we can catch it in early disease. And I think obviously the target for a lot of those compounds has been severe asthma, but I think, you know, a lot of the pharmaceutical companies are now branching out to other conditions as well. And I think that's something that I think there's going to be quite a lot of movement in the next few years, which is closer towards the clinical use, because these are compounds that are already licensed and available and being used. And then, like Darius said earlier, I think there's a big pipeline of novel antifungal medications, which really increase the scope in terms of what our ability to treat these these conditions with, in terms of novel oral type agents. So it allows us to consider combination therapy, allows us to consider multiple class type therapy, which hopefully could be game changing in terms of keeping control over diseases that are very, very difficult and high rates of antimicrobial resistance. So I think for me, that's probably where the immediate game changing research and hopefully clinical translational impact could be.
Perfect. Well, that's all the questions I had from our viewers. I'd like to thank you very much for taking the time to talk to us. We'll post this on our website for everybody's view. So thank you very much.
Yeah, thanks, Bart, and thanks for putting it together. It's it's a great opportunity to communicate with people in a really constructive way.
Thank you very much, and appreciate the offer to talk.
Thank you.
Thanks.
Okay.
Merry Christmas.
Bye bye.